mostly a recent approaches among all the psychotherapeutic forms, isn't it? Right. So can you guys kindly briefly let me know, or just put it in your just for the comment section of what's your understanding about DBT, or what are all the things that you know about dialectical behavior therapy, or what popped up to your mind immediately after hearing DBT. I just wanted to understand. You just mention in words, no need to describe anything much in detail. Let it be one or two words. I hope I'm audible. Yes, you can use thumbs up emoji. Right. Okay, it is used for identification of emotional dysregulation. Okay, okay. Right. It is used for identification of emotional dysregulation. Rather than identification of emotional regulation, we can also consider one of the primary goal of dialectical behavior therapy is to achieve this self-regulation or emotional regulation. And then the target audience on whom that we can use can have emotional dysregulation. Right? Okay. Very good, very good. I can see a lot of responses. Let me summarize that. Radical acceptance, very good. And then a lot of people are talking about acceptance, radical acceptance. Very, very good. And then this is one thing which the attitude, the approach towards the client, or the approach towards the problem an individual can have, is what differentiates the third wave psychotherapy from cognitive behavior therapy, isn't it? Because when it comes to mindfulness based cognitive behavior therapy, dialectical behavior therapy, MBCT, or we can also have acceptance and commitment therapy, all those forms of psychotherapy comes under mindfulness based cognitive behavior therapy. And then, as I mentioned earlier, it is the what differentiates, the core difference between the previous form of cognitive behavior therapy and then the most recent forms of cognitive therapy is about the attitude an individual have or carries towards the symptoms that they have or the problem that they are facing. So that one thing is about non-judgmentality, and then another thing is about the acceptance. We'll definitely discuss about that in detail. Okay, it's a talk therapy. Okay, about accepting the reality. Okay. So it's not just about accepting the reality. The word dialectic means two opposite poles. Integrating two opposite poles is what we consider as dialectic. Both extremes can be there or present during a same time. Acceptance and change. That's what the dialectics stands here, right? Not just the acceptance part. Will also motivate the client to change what is actually distressing. Okay, changing thought patterns. Definitely, we'll be focusing on thought patterns because it is mindfulness-based cognitive behavior therapy approach, isn't it? So, to summarize any form of psychotherapy, it is very essential for us to understand the primary focus of therapist. So, how do we have to understand the client? That we can understand clients in 4 different vectors, isn't it? That you can just divide them in any individual experiences into 4 different aspects. What all that? Thoughts, emotion, behavior, and physiology, isn't it? And then as a psychiatrist, people would be predominantly focusing on their physiological aspects. And then even if you compare the degree of control that we have among all these 4 aspects, the amount of control is very, very, very less on the physiological aspects, isn't it? That we cannot easily regulate our heartbeat, or is it's not easily easy for us to regulate our sweating, isn't it? For those aspects, we may have to rely on the pharmacotherapy. But apart from the physiological aspect, we again have other 3 different vectors: behavior, cognition, or thought, and emotional aspects. Right. So as a therapist, we'll be focusing on all these aspects. But again, our predominant focus would be on the thought level and also on the emotional aspects, because the longevity of the cure, or imagine that the individual has got better or has obtained their goal, right? So the longevity of the achieved goal will be more if we just focus on the thoughts, right? But it will be easy to control our behavior, but on a longer run, the relapse could be more. The probability or the possibility of the relapse of the certain behavior would be more. If any changes happens in the level of thought, we consider that the longevity of that change would be relatively more, right? So that's why predominantly we are focusing on this thought level and also on the emotional level. Obviously, we have a lot of techniques to deal with behavioral responses as well, right? So primarily, you need to understand these 4 different vectors whenever that you are trying to understand your goal, your clients, and also if you're formulating your goals. We just have to conceptualize our goals based on these 3 different vectors, apart from this physiological aspects, which we have very less techniques and controls over it, right? Okay, it's a form of CBT, right? It's a form of CBT, and we can also consider it's an advanced approach than CBT, right? Okay, type of talk therapy to regulate emotions better. Okay, that is one part of goal, right? DBT is not just focusing on this emotional regulation part or to regulate our emotions well, right? There are multiple goals of DBT, which we'll definitely discuss later. Works with emotion, type of CBT, a second perspective to anything. Okay, I've used in treating BPD. Very good, Nitya. And then initially, dialectical behavior therapy has been conceptualized to treat or intervene individuals having borderline personality disorder, or according to ICD, we can consider that as emotionally unstable personality disorder, right? But in the recent times, it has also been found to be effective across various psychological disorders and also on a lot of psychological conditions, not just for disorders, right? There is where the boundary between clinical psychologist and the counseling psychologist or other psychologist comes into the picture, right? I just wanted to clarify this one, like, because most of the clinical psychologists, I also assume that there are a lot of clinical psychologists here, right? So I just wanted to draw a boundary, and then whenever that I'm trying to give you some examples, I predominantly try to stick it with non-clinical population here, right? So what I really mean is non-clinical population is that anybody who don't have mental illness, right? That is one primary aspect. I'll again try to be more specific about the boundary issues. For example, consider an individual who has just got him into an college, right? He just passed from school and then entered into a college level. And then we consider that as a transition, isn't it? That one of a major life transition an individual can go through. And at that particular point of time, any individual can have a different amount of adjustmental problems, isn't it? Of a varying intensity. An individual can have a very mild level of adjustmental difficulties, but he can just cope up with it just by calling his mother once a while, or once a week, or once a day, right? But on another spectrum, an individual can have a significant amount of adjustmental problem, which can obviously expresses in the form of anxiety, depression, or any other emotional concerns, or limiting their functional aspects of their daily living, isn't it? Right. Again, when can we diagnose them as having disorder? According to DSM or ICD, we have a 6 months time, right? And any individual can take around 6 months time in order to adjust to their new environment. That is one particular aspect, right? That's where the boundary comes in. And then again, going into the detail of it, any individuals who has an excessive amount of distress, and then who have an excessive amount of dysfunctions in their environment, right? At that time, we can obviously have to refer it to a clinical psychologist, right? If an amount of distress is in a range of tolerable to an intolerable level, on a moderate level of distress, and then they could be able to engage in the environment well, but they are not able to excel in their environment. At that time also, counseling psychologists can deal with this. They deal with those clients, right? Whenever the amount of distress is too much, and then the level of dysfunction is too much, at that time, there has to be a call with whom that you can refer to a clinical psychologist, right? Then there's again another example called grief. Any individual who actually perceives a loss or experiences an actual loss can have a preoccupation or longingness or have a low mood or have a loss of interest in their environment. All those things can obviously happen, right? But again, it's about the intensity of their experiences. And then also, we obviously give them with 6 months of time as a grieving period. Even after the grieving period, an individual have still have continuous preoccupation about the lost object or this earning, longingness, or as I mentioned about this low mood. All these things or experiences are still pertaining. At that time, we have to take a call to refer it to a clinical psychologist, right? Because grief is a very usual experiences where everybody goes through, but it is again about the amount of intensity and also about the level of dysfunction an individual goes through. Understood? That's where this boundary takes place. And then in case if an individual has diagnosable level of depression, diagnosable level of anxiety, or any other condition which has been mentioned in ICD or DSM, counseling psychologist must straight away refer it to a clinical psychologist, right? So that's what the boundary. And then the primary intention for me to explain this particular boundary is again the question of whether a counseling psychologist can use DBT or not, whether a counseling psychologist can use CBT or not, isn't it? Most of you must have encountered this particular kind of question. As a counseling psychologist, how can you practice CBT? As a counseling psychologist, how can you practice DBT? Have you ever come across this particular sort of questions in your practice? If yes, just put a thumbs up. No? If not, that is great. Okay. In case if you are getting in, get any such questions in the future, right? Try to explain them that you're not okay. Oh, right. I must have waited for some time. Right. So the thing is that the basic principles and the techniques of dialectical behavior therapy, cognitive behavior therapy, and any form of psychotherapy can be used by a counseling psychologist. But the target audience has to be very specific, right? So the clients for a counseling psychologist should not have a diagnosable mental illness. That's it, right? So apart from that, and any other techniques or any principles under psychotherapy can be used by a counseling psychologist as well, right? Okay. Let me just quickly go through the other things. Okay, used to treat PTSD, yes, personality disorder, and then it's also be found to be very effective for eating disorders and to manage intense emotions. Okay, manage their okay, called the talk therapy. Mindfulness, where the patients keep a diary to understand their emotions and feelings. Okay, right. So primarily, mindfulness is to enhance their awareness. I'll talk about mindfulness in very detail because mindfulness is one module among four different modules of DBT, because DBT has been focusing on four different modules where they stress predominantly on the skill acquisition, right? One particular module is this mindfulness. Again, I'll try to, if time permits, I'll definitely try to coach you or I'll guide you how you can explain mindfulness to your clients, isn't it? Because everybody can experience mindfulness, but it'll be very difficult for you to explain it to your clients, isn't it? Like, because in the initial practices that I had lot of difficulties, because it's a very mindfulness is more of a very subjective experiences and also considered to be a very abstract concept where it is very difficult for us to explain it to our clients in a real therapeutic situations. I'll try to tell you how we can specifically tell them and then break mindfulness into a very concrete part and then make them practice in their real life. Yes, yes, very good, Varshini. It's also definitely used for substance use disorders. Good, Ramesh. You're addressing about this dialectic called acceptance and change, where we are trying to balance these two things, or can practice both at the same time. Can you guys see my slide now?
Yes, sir.
Oh, great. Okay. Right. So let me start with the presentation then. So this is what the overview of my presentation today or our discussion today. I'll be mentioning about the brief introduction about the DBT, and then we'll also discuss about 4 primary characteristics of DBT, and then one important part which I would mention is about this biosocial theory. I find it very, very interesting. I hope I'll also present it in a very interesting way so that it makes you also to curious to learn about this particular theory more. And then as DBT, it has around 5 basic functions. And then there are 4 different elements of DBT, and then 4 functions or focuses on 4 different modules, right, which is specifically on building an individual's skill, right? So that this is what the crux of my presentation. So to have a brief introduction about dialectical behavior therapy, as I also briefed or mentioned here and then earlier, Marshall Lenin is the one who developed this particular approach in late 1980s. And then, as I mentioned earlier, it is specifically designed to intervene individuals having self-harm behavior. And then since most of the individuals who had self-harming behavior also had a comorbid personality condition called the borderline personality disorder or emotionally unstable personality disorder, right? So that's what the predominant focus of this dialectical behavior therapy in the initial time. So similarly, if you take cognitive behavior therapy, so that also has been initially developed and devised to treat only depression, right? Isn't it, Aaron? Right? Designed cognitive behavior therapy to intervene depression, but lately it has been widely used across various psychological conditions and then mental health disorders, isn't it? So similarly, dialectical behavior therapy has also been initially devised to intervene or to treat individuals having suicidal behavior or self-harming behavior. And later, it has been widely used across various other conditions and also for psychological problems, right? And then in case if you just take the basic philosophy of this dialectic, so dialectic in the sense that we need to understand 2 opposite poles, right? We just attempt to bring in 2 opposite poles into integrating these poles, opposite poles. So here the opposite poles is between acceptance and change, right? We may have some or the other difficulty within our personality aspects or in ourself, which we obviously have difficulty or which can interfere with our daily living, or in order to achieve your goals, some aspects of yourself or some aspects of your personality can be a hindering factor or be a hurdle to achieve your goals, right? Rather than just focusing on change, because cognitive behavior therapy and also addresses about this acceptance. But if you just try to refer to Judy Aaron Beck daughter, right, Judy Beck, so her text on cognitive behavior therapy, she places acceptance as the last resort, right? They primarily focus on change or change behavior or change cognition or our emotional aspects, and then CBT considers acceptance as the last point or last resort. Rather, dialectical behavior therapy brings it as the first primary attitude, right? We just have to accept whatever the difficulties or whatever the limitations an individual have at any point of time, but at the same time they can actually work through the change process, right? So that's what this the primary crux or philosophical crux of this dialectical behavior therapy. And then I'll just briefly take a moment to differentiate between rational emotive behavior therapy and cognitive behavior therapy, isn't it? Because both are cognitive based approaches, isn't it? Like it comes under a umbrella of cognitive therapies. So when it comes to the basic differences between rational emotive behavior therapy and cognitive behavior therapy is that rational emotive behavior therapy stresses more on the rationality, right? And then if you just consider the techniques of rational emotive behavior therapy, it'll be too much confrontative, right? It'll be argumentative, right? When we have to present a lot of faulty errors, right? We just have to confront individuals with their faulty thinking, and then we label it as irrationality, and then we insist on building rationality, isn't it? Like it's a very strict and confrontative approach. But when it comes to cognitive behavior therapy, it's not a very strict, directive, and confrontative approach, right? But again, as I also mentioned earlier, DBT also has a lot of cognitive behavior therapy based techniques, but the primary differences is on the attitude that we carry while pursuing the treatment, right? Where they primarily focus on this acceptance, mindfulness, non-judgmentality as the primary attitude of our client. As I also mentioned earlier, initially DBT has been devised to treat borderline personality disorder or emotionally unstable personality disorder. In the later times, it has been found to be effective on mood disorders, sexual abuses, or any sort of chemical dependence, as we mentioned about substance use disorders or eating disorders. Right. Again, when it comes to the four key characteristics of dialectical behavior therapy, as I always been mentioning about this acceptance and change, right? The philosophy of this dialectic or dialectic philosophy. And then the second part is about structured and comprehensive approach. Unlike it's more similar to all the other forms of psychotherapy. Most of the psychotherapies that we have, or the forms of psychotherapies we have, are a very structured approaches. And then what makes this is comprehensive is about this the focus of this techniques on behavior, and then we have techniques to address emotionality, and also the techniques to address the cognitive parts, or the faulty thinking, or the negative thinking patterns, right? And then the third key characteristics about this dialectical behavior therapy is about this hierarchy of treatment targets, right? I'll tell you one unique goal of this dialectical behavior therapy, because most of the other therapies wouldn't mention that as the primary goal. But dialectical behavior therapy mentions that as the primary goal, or the initial goal of dialectical behavior therapy. Is that the first goal, or the primary goal of dialectical behavior therapy, is to keep the patient alive, or is to keep the client alive, right? Because in when do we generally consider dialectical behavior therapy? Initially, whenever an individual have suicidal behavior or any form of severe self-harm behavior, isn't it? Right. Pramod Chowdhury is not able to see the presentation. Any others also facing the same error?
No, we can see the presentation.
Okay, you guys can see the presentation.
Yeah.
Right, great. Okay, right, I'll continue. Right, so as I mentioned earlier, so primary goal of dialectical behavior therapy is to keep the patient alive, right? Unlike other psychotherapies. And then we also focus predominantly on the skill enhancement, right? And also to improve their well-being. So these are all the primary goals. If you just ask me, one thing is to decrease the life-threatening behavior, or to stop the self-harm behavior. That is one particular goal. And then the second or other two goals, like first place that you can have one goal, and then the second level you can have two other goals, which is again very predominant. One thing is improving the quality of life, and also to improve their skills, daily skills. And then skills has been categorized into four components. That's what going to be the last focus of our discussion, because whenever that we talk about skills in dialectical behavior therapy, dialectic DBT has been given with a lot of techniques, right? And then a lot of techniques which can be adopted to our daily life. Even for within our own self, it will be very, very useful. Right? I'll point out to this four specific skills called interpersonal effectiveness, mindfulness, emotional regulation, and then the last factor is about I mentioned about mindfulness, interpersonal effectiveness, emotional regulation, and then distress tolerance. Right? These are all the four primary skills or set of skills that we have to equip our client, right? And then if you just reflect on these four different components, or four different components of skills, it will be widely useful across mental health conditions, or imagine within ourselves, right? Reflect on our own self. we ourselves can have difficulty among all these or one or the other four primary components which has been addressed by dialectical behavior therapy. Right, Titi, I'll definitely mention about these four. We have it in the presentation. That's going to be the important part of our discussion. I'll try to spend around 15 to 20 minutes in that particular concept. Right. Right, and then what makes this a lifelong or long-term therapy is that even if you just compare it with again with cognitive behavior therapy, we roughly mention the number of sessions for individuals having mental illness. CBT number of session of CBT is between 16 to 20 sessions is what the usual thing that we talk about. That's a very rough number, right? We don't have to commit to any specific numbers. Rather, we can tell them that within 5 or 6 sessions, after 5 or 6 sessions, we can expect change. Right, so that's what the commitment that we can give, rather than giving that the individual would be definitely get better after 5 or 6 sessions, or definitely would get better in 15 or 20 sessions. That cannot be a actual promise a psychologist or ethical practitioner can have. Right, we can just tell them that after 5 or 6 sessions, we can sense some changes. Right, we can find some changes. That's what the commitment that we can have. But what makes this is a lifelong process, that as I mentioned about the usual number of sessions in cognitive behavior therapy, it ranges between 16 to 20, isn't it? But again, when it comes to CBT for personality disorder, we cannot really commit to a specific number. Most often it stretches for years, and then after 15 or 20 sessions, we space the session very widely, as in the time gap between one session and then another session can be even for months. Right, so that's what we consider as lifelong process or long time processes. Fine, right. And then again, the third part of our presentation is about this biosocial theory of borderline personality disorder. Right. In case clinical psychologists, if you have a clinical psychologist here in your training, you must have definitely come across a lot of conceptualizations, isn't it? And then if you just for others, for those who are not from clinical background, I'll just mention about this conceptualization, because if you just take anxiety or just the generalized anxiety disorder, we have 3-4 amount of cognitive behavior therapy conceptualization. Right? Everybody, like for example, if you just take obsessive compulsive disorder, you can find a PPT in SlideShare. I have shared one of my PPT in SlideShare. You can just search for psychopathology of OCD. I'll just mention. Okay, psychopath. Definitely, Manya, I take your input. I'll space my voice down. I feel that there is a sense of urgency from my end, because I'm also monitoring the time, so that I just have to give as much knowledge as possible. That's why I'm just going little faster. I'll be more conscious from now, Manya. Right. So you guys can kindly refer to the psychopathology of OCD. There are around 4-5 conceptualization within the context of cognitive behavior therapy. Right. So again, if you just take other conceptualization, you can consider psychoanalysis has a conceptualization of OCD, and then behavioral therapists again have conceptualization towards OCD. Right. And similarly, that for any specific disorders, there can be multiple perspectives to explain why this particular disorder would have evolved, isn't it? Again, when in usual counseling aspects also, it is very essential for us to understand the aspects or conceptualize our client's problem as a whole, isn't it? And then it is very important for us to understand the precipitating factor, or the predisposing factor, or the perpetuating factor, all those things, and then the protective factor. The 4 P's is again very, very important. That's a very usual conceptualization, or a very fundamental conceptualization that any counseling psychologist can make a 4P model. I'll repeat once again. One thing is about the predisposing factor. Predisposing factor as in what are all the factors would have been already there within the individual even before the onset of the illness or onset of the problem. That's what we call it as predisposing factor, predisposing, right? And then we have a second factor called perpetuating factor. Yes, genetical factors can be a predisposing factor or a personality factor or a cognitive ability. All those things can be considered to be an predisposing factor, or just consider, like most of us would as psychologists, we may not be very sensitive towards this particular issue. I'm not mentioning everyone, but most of us would not, like maybe I am just projecting myself, comparing to my initial time of practice. I was not very sensitive about their social background or the economical background or the caste that they are coming from, right? But again, as a psychologist, it is very important. All these things can be a predisposing factors, right? So that is very important for us to understand, right? Apart from that, we again have to consider about this perpetuating factor. Sorry, we talk about the precipitating factor. Precipitating factor are nothing but the event or any specific factors which contributes to the onset of the illness, right? What happened immediately before the onset of the illness? Very good. What triggers the onset is what we call it as precipitating factor. And then we have perpetuating factor. So perpetuating factor is more like a petrol to a engine, right? Or petrol to your vehicle, right? What runs it, right? What makes this particular, what are all the factors contributes to the continuing of this particular psychological distress or illness is what we call it as perpetuating factor. And then as a therapist, it is very important to understand the protective factors, right? Because enhancing their protective factor will again help them to deal with their problem better, right? Is my voice tone correct, or should I slow a little down also? Am I at the right pace? Thank you so much for lot of thumbs up. Okay, right. So coming back to biosocial theory of BPD, right? There are a lot of other approaches, or there can be multiple perspectives towards the same disorder, and then this particular perspective is called as biosocial theory of borderline personality disorder, which talks about the onset or what would have perpetuated or what would have actually made them become pervasively emotionally dysregulated individuals, right? Again, this particular theory is can be very much useful to explain a lot of symptoms or yes, a lot of diagnostic criteria of borderline personality disorder. I don't think that it would be very relevant for me to take those examples. Rather, I'll try to explain what do we mean by emotional vulnerability, and then what do we really mean by invalidating environment, and about this pervasive emotional dysregulation, right? Right. First factor about this emotional vulnerability. What we generally mean as emotional vulnerability is about their biological aspects, right? As we were mentioning about the predisposing factors, an individual can have a lot of predisposing factors. Like for example, one factor that I would want to mention is about this sensitive sympathetic nervous system, right? Or you can consider it as hypersensitive sympathetic nervous system. What is the primary role of sympathetic nervous system? It triggers, very good, very exact answer, Alka. It evokes fight or flight response, isn't it? It tends to expend, it forces us to expend our energy, isn't it? It increases our heartbeat, it increases our galvanic skin response, and then it increases it activates our sweat gland, isn't it? There can be multiple ways in which it increases the general activation, and then the blood flow to the muscles would be high, and then the blood flow to the internal organs will be very less. All these things can happen when our sympathetic nervous system gets activated, isn't it? Right. So imagine an individual have hypersensitive sympathetic nervous system. And then when do this sympathetic nervous system get activated? Whenever that we perceive some threat or danger, isn't it? We feel anxious, or whenever they feel fearful, all those times that we can feel this increased sense or this activation of sympathetic nervous system can happen, right? So imagine a person have hypersensitive sympathetic nervous system. Even for a very less amount of distress or a very less amount of threat, an individual's sympathetic nervous system would get activated. Right? What will happen if that system get activated? Obviously, we'll have adrenaline rush. In response to that, as I mentioned about all those physiological responses, heartbeat, blood pressure, galvanic skin response, and then sweating, tear, most of this physiological components would get agitated, isn't it? Right, right. So that is one particular example for this emotional vulnerability. An individual can have hypersensitive sympathetic nervous system, right? And then there are the recent approaches are predominantly mentioning about a lot of neurobiological aspects into this borderline personality disorder. And then there are multi-integrative approaches has also been coming up. That's a more recent form of psychotherapeutic approaches, right? So that is one part of borderline personality disorder. An individual can have sensitive or can have emotional vulnerability at one part. And then another part is about a very important part, which is again very important for not just for therapists, also for parents. It is very, very important, right? Called invalidating environment, right? So Marshall Inen has given us with specific characteristics of this invalidating environment, right? For example, one part of invalidating environment would be this pervasive criticism, right? Criticism at once or twice can be acceptable, right? But pervasive criticism, as in like continuous amount of criticism towards the expression of emotion or expression of any sort of emotion related behavior, can be considered as an one characteristics of invalidating environment, right? And then another characteristics of invalidating environment could be minimizing or trivializing, right? Or we can also consider punishing or excessively or erratically reinforcing the internal experiences. Whenever the individual is communicating their internal experiences, we can rather pervasively punish them, or an individual from the invalidating environment can pervasively or erratically reinforce them. I'll give you an example here. Imagine the child is studying 5th standard, right? And then it has participated in a running race. So it's a school competition. It's a school sports day. It has participated. And then the child has secured first prize. What would be the amount of happiness the child can have? It can obviously have a very high amount of happiness because of this achieved competence or this improved competence. So, and then the child is bringing the certificate and the medal and then happily showing them to their father and mother. What would be an ideal response would be? We can just pick them, hug them, congratulate them, and then tell them that we are so happy for their success, isn't it? Those are all the common responses that we can expect. Consider an individual from or parents from invalidating environment. As I mentioned about this minimization or trivializing responses. Rather than encouraging them or reinforcing them or showing them the equal amount of happiness that they experience, consider that the father is asking how many children has really participated in the event. The child is saying 5 people participated in the running competition. Okay. Oh, those 5 people are from the same class or from different class? They are all from my class only. The child is responding that they are all from my class only. And then the father is responding, see, it's just a class level competition. And then it is very simple and easy for you to win or get success in this. Why are you be so happy about it? Just throw those certificates and the medal and then come, we'll have a food. You take care of your health now. What would be the amount of, what would be the kind of internal experience the child would be at that time? Imagine the discrepancy that they feel between what they really experiences and then what I actually have to be experienced. There can be a huge discrepancy, isn't it? That's what we call it as internal experiences. Minimizing or trivializing the internal experiences is this, right? It actually questions their emotional expression fundamentally, isn't it? Like they again get a lot of questions. Should I be really happy about it, or did I really do something wrong? I shouldn't have really been very happy about this particular event, is it? So those are all the confusions that they can have. And then self-doubt is very specific towards their emotional expressions, or that's what we call it as communication of internal experiences, right? So whenever the child is communicating their internal experiences, the invalidating environment can trivialize, minimize, or criticize, or excessively reinforce, or erratically punish. These are all the common characteristics of this invalidating environment. In response to it, an individual can get a resultant pervasive emotional dysregulation. Right. Again, it is very important for us to know what do we really mean by pervasive emotional dysregulation, because most of us, if I just ask you to describe what do we mean by emotional dysregulation, we may come up with the words or terms like difficulty in regulating emotions, or expressing intense emotions can be considered as pervasive emotional regulation. Rather, we just have to talk about three specific factors. Right. One thing is about this heightened reactivity. Just make a note of it. Reactivity, sensitivity, return to baseline. Reactivity, sensitivity, return to baseline. These are all the three components, right? What differentiates a normal individual from an emotionally dysregulated individual is these three things. First part is about this reactivity. So reactivity is in the sense how much time you would take to reach the intense emotional experience. Most of you would be obviously feel happy, or most of us would obviously experience anger, isn't it? All those experiences can be there. It is very quite normal to experience any intense emotions. But again, the time or the time period or the latency in reaching the intense emotional experience. People having borderline personality disorder would be triggered very easily, right? They can the reactivity would be very high. That's what we consider as heightened reactivity. From baseline to intense emotional experience, they can go in seconds or few seconds. They'll just reach this heightened emotional reactivity, right? And then the second part is about the sensitivity. How long an individual would be spending time in their intense emotional experience. We have a baseline here, and then we take time to reach the extreme emotion. And then people having borderline personality disorder or emotionally unstable personality disorder will spend a long time in the intense emotional experiences, right? And then the last part is about this return to baseline. Individuals having borderline personality disorder will again have a very slow return to baseline. They take long time to return to the baseline, right? So these are all the three specific characteristics we need to understand when it comes to pervasive emotional dysregulation, right? Give me a minute. I'll just drink some water. Right. Okay, so the three parts I'll quickly mention about three components of this emotional dysregulation. One thing is reactivity, and then sensitivity, and then the return to baseline, right? So just assume a graph. So start from a low point. That's what we call it as baseline. individuals having borderline personality disorder will have a heightened reactivity, as in just draw a line like this. Don't be slow slant. Try to be consider it as a 80-degree or 75-degree line from a baseline. They'll quickly go to their experience this intense emotional experience, and then the longevity of that particular experiences will be very long comparing to a normal individual or individual having no emotional dysregulation. Right, the longevity will be very high, and then the return to baseline. Again, we have to become normal, isn't it? People having borderline personality disorder will have a very slow return to baseline. Again, from that point, you can just consider 30-degree angle or 45-degree angle. Right? They'll take very long time to come to a baseline emotion, or a feeling of normalcy would be attained very delayed. Right? How is being sensitive a characteristic for borderline personality disorder? Can you elaborate? Okay, Sugana. Like, I mean, emotional sensitivity. That's what I mentioned as the longevity of the intense emotional experience. Okay, again, we have a huge model which we would be launching our intensive training on DBT. We'll just cover that because due to the time constraint, we may not be able to discuss this. Right. I'll quickly jump into the last part. I'll just brief about this basic functions. Right. So as I mentioned earlier, the fundamental goal of dialectical behavior therapy is to keep the client alive. Right. In order to the first goal at the first level, we have a goal to keep the client alive, right, or to reduce the what is that to reduce the life-threatening behavior. And then at the second level, we have two different goals. One thing is to improve their well-being, and then to improve their skills or make them more skill acquired. Right, these are the primary functions. And then talking about four elements of dialectical behavior therapy. It's not DBT, it is DBT. Four elements of dialectical behavior therapy. One thing is about this individual therapy. DBT can be conducted in individual format and also in a group therapy format. Right, when it comes to specific skills training, we can obviously consider it under group format. And then whenever that you are focusing predominantly on their interpersonal or intrapersonal factors, it will be important to conduct the individual therapy as well. Right, and then the second part is about the skills training, which we will be discussing in the near future, like the second module. Right, and then about this telephonic coaching. This would be very relevant for the clinical psychologist because again, when it comes to dialectical behavior therapy, we are focusing on individuals having suicidal tendencies, isn't it? And then the suicidal ideation can pop up to individual at any point of time, right? So at the first level, we just have to tell them that at any point of time, you feel if you have thoughts of killing yourself, please try to reach out to me. Right, that's what the one thing that we can tell. And then we should also tell them, even if I'm not able to attend the call because of my current appointment, because it will not be easy for us to respond to our clients at any point of time, isn't it? Like within our work time, we can tell them like this. This is what my usual work schedule is. You can call me anytime during the working hours. And then in case if I'm not able to pick up your call because of my current appointment, I'll definitely try to call you back between my sessions. Right, and then it is also very important for us to provide them with free helplines, contact numbers, so that at any point of distress they can obviously take help from other resources as well. And then again, we again have to importantly mention our client to take a note of take a list of friends or relatives or dependable person, right, so that they will be very helpful to call them back. And then we also have therapist consultation. Therapist consultation as in the peer consultation or supervision. It is very important for the therapist who is practicing dialectical behavior therapy. Right. So these are the 4 modules is what the primary focus. I'll try to spend around 15 minutes here. I'll try to equip you with specific skills and techniques. I also assume that this is going to be the crux of dialectical behavior therapy, because like this is what we are actually going to do in the therapeutic format, right? So as again mentioning about this skill acquisition and improving well-being. So again, these 4 modules would be very much helpful to build both the secondary goals apart from the primary goal of keeping the client alive, improving well-being, and also to improve their skills of their daily living or their and intrapersonal skills. These 4 modules would be very much helpful, right? So first module is about mindfulness. Again, I'll specifically discuss about all these modules more in detail in upcoming slides. So I'll just mention about this mindfulness, and then second part is about this distress tolerance. This is again an ability to tolerate our own distress. Everybody would be feeling some amount of distress, and then we all have some or the other coping mechanisms to cope up with it or response to that distressing factors, right? But again, people having dialectical behavior therapy can have a decreased distress tolerance ability, right? So that also can be discussed. And then the third and fourth part is about this emotional dysregulation, and then this interpersonal effectiveness, right? Okay. So as I mentioned earlier, first part of the discussion is going to be on mindfulness. Okay. Right. Again, as I mentioned in the initial part of the session, I got to know about mindfulness when I was in my post-graduation. First year of post-graduation or the third year of undergraduation is where I got to know about this mindfulness. And I slowly, gradually started learning about it, and then started to integrate the practices. And then I also strongly believe mindfulness is not just a technique which can be used in the time of distress. Rather, it has to be integrated in our lifestyle, isn't it? I again insist this mindfulness, and also primary aspect is about this attitude of mindfulness, acceptance, non-judgmentality, isn't it? All these components are a primary attitude of individuals who practice mindfulness, right? So again, as I mentioned, technically we consider mindfulness as a here and now experiences, right? Why I mentioned about my personal relevance is that I got a lot of awareness, and then I got to work on myself after understanding and after practicing mindfulness a lot. Right, I was very impulsive. I was very agitated, and I can easily hurt people, and I also dominate people very well. All these aspects were there during my undergraduation, considering the kind of environment that I was brought up. I'm not blaming the parents, rather I'm mentioning about the cultural factor where I was coming from. Right, I was from a rural part of Tamil Nadu, Madurai, and then I had a lot of difficulties with my temperaments. And then this particular mindfulness practice has helped me to transform a lot. I don't mean to say that I have transformed completely and I have reached the same level. Definitely not. But I have definitely reached a very functional level, which supports my goal orientation and also effective communication in the relevant aspects. Right. Again, stressing on this mindfulness, one particular factor of mindfulness is about the self-awareness. That's what this why question is. Right. So as I also mentioned in the earlier section, where I'll tell you how you can actually communicate, or how you can tell your clients about this. I explain your clients about this mindfulness. Right. First and foremost, what I generally tell is that mindfulness is more of a Eastern philosophy. It's more. It has been drawn from a Buddhist philosophy, isn't it? It's a Buddhist practice. And then in the recent time, if you just consider last decade or last 15 years, around like most of the RCTs, randomized control trial on mental illness or psychological distress has integrated mindfulness practices. It has been found to be effective. There is no question about the effectiveness of mindfulness in the recent advanced psychotherapeutic interventions, right? So that is one point. And then another point that we have to mention, what is mindfulness is. So mindfulness is not just a practice of when you are under distress. Rather, we have to integrate it as a practice of living, right? That is again another important point, right? And then I'll also explain them about this three axioms of mindfulness. So three axioms is nothing but this three different answers, this three different questions. So I mention it as IAA. It's not me. There is a relevant study which has been mentioned. I'll try to share it in the group after this. So they call it as mechanism of mindfulness, right? It's about IAA. Yes, IAA. So stands for intention. A stands for attention. And then the third thing is about third A is our attitude, right? So why should we do mindfulness? That's what this intention is. Second thing is A stands for attention. What should you focus on? Isn't it? Because mindfulness is here and now. We just have to focus on the present, isn't it? But what should they focus on? That also be mentioned concretely. That's what we call it as attention. And then the third thing is about attitude. How should I practice mindfulness, or what are the general ways in which I have to carry myself in the real world? Right? Mindfulness is not just a meditation. That's what I mentioned a little earlier. It is not at the you can practice mindfulness once a day or twice a day. No, you can obviously practice once or twice a day also, but again you can integrate that in your own self, right? We can practice it as a way of living, right? So first part about this intention can be in a very larger spectrum, right? It can start with self-awareness, right? Intention can just to improve our self-awareness. Why awareness is important? For you to bring any change in your behavior or any change in your thoughts or any change in your emotionality, it is very important for us to know what is happening when. For a very basic example, consider knuckle thing. Like I'm just cracking my knuckle. Right? That's a general practice that I have. And I also want to work on this particular behavior. How can I work on this behavior without having awareness? I should have an awareness of when am I actually cracking my knuckles, isn't it? That is very important and essential for me to know, isn't it? So then only I can bring in some or the other changes into that particular behavior, right? So that is what this awareness. So intention can just to bring awareness to our limitations or our behavior, or it can also help the general this mindfulness can help you to transcend or like the transcendence, achieve this transcendence. For example, so like transcendence is nothing but a feeling of oneness with the universe. Mindfulness can be used to reach or achieve this transcendence. But most often in the real life scenario or within our cultural and societal context, that may not be a good goal, isn't it? Like we all would have been tied up with a lot of responsibility within ourselves. So we can just start with this self-awareness. So intention for using mindfulness, or why should I practice mindfulness, can be answered with this improving self-awareness. And then second question is about what. What should I focus on? Because we are asking them to be present at the moment, but most of the time like we would be thinking about something or worrying about something or anticipating about something, or predominantly we'll stick with the future or the past. If we ask our client to be at the present moment, it will be difficult for them to be on the present, and then it is essential for us to tell them what they can focus at any point of time, right? What they can focus is on primary, the first point of focus or attention that they can have is on their breathing, right? They can just focus here first, the nostrils, the air, the air, comes in, right? And then slowly they can have a focus on then they can just continue or follow the air which goes through their nostrils and then esophagus and then fills the lungs and then spreads over the whole body, and then they can just focus on coming out all the way from the different parts of the body, right? That is one part. The first basic part can be on their breathing, right? Once they start achieving that particular focus, they can slowly start focusing on their sensory aspects, right? We usually tell them with grounding techniques, isn't it? 5 things that they see, 4 things that they hear, 3 things that they smell, 2 things that they taste, or 2 things that they feel, sense, or 1 thing that they taste, isn't it? So practicing this 5 grounding techniques, or just focusing on their sensory inputs without judging them, right? They cannot just consider that hey, I'm sensing something very not nice, which is very foul in nature. Not like that. They just have to be at that moment, at the present, without judging the experiences or without comparing one experience with another experiences, right? And then the second, the focus is on the sensory inputs, and then the third level, they can just focus on their thoughts and then on their emotions. And then the extreme part of what we can focus is on stillness, right? Having focus on nothing is what actual mindfulness is, right? Having nothing in our mind, this is very, very difficult for any individuals or a normal being like me to achieve it. I hope everybody would agree to it. But basically on mindfulness, as I mentioned about this spectrum of intention, from starting from self-awareness to transcendence, this what factor can also be at the spectrum, focusing on breathing, sensory inputs, thoughts and emotions, to the fact of feeling of stillness, not having attention on anything, can again be considered as the extreme part of mindfulness. And then third approach or third axiom is on this attitude, right? How should I practice mindfulness? As I again mentioned earlier, having an attitude of acceptance and then having an attitude of non-judgmentality. These things would definitely help you. I hope this was helpful for you to explain this to your clients. Is it? Can I have thumbs up? If yes. Great. Right. Thank you so much. Yes. Right. Now we'll quickly move on and discuss about this emotional dysregulation part, and then I'll take last 10 minutes to answer the doubts if you guys have any. Right. Okay. So the second technique, we may not be able to cover all 4 components, but I'll try to share some of the other materials so that you guys can refer to it and make yourself effective. Right. And then in case if you really feel that this is a very good place to learn, we'll be rolling out detailed or extensive training on dialectical behavior therapy maybe in January. I would definitely expect you all there. There we may have restrictions with the participants because we really wanted to give a proper training. So that's why we are restricting participants in our most of the professional training programs. Okay. So we'll try to discuss this emotional regulation activities, and then I'll take up the questions from the audience. Okay. Just a minute. Okay. Right. So there are multiple techniques under emotional dysregulation as well. So the first and foremost thing is about this identifying and labeling emotion. Right. I also assume as a psychologist, we are all blessed to have a basic level of awareness. Right. I may not mean to say that every psychologist will definitely have a high amount of emotional dysregulation or ability to label their emotion. Rather, we can just try to understand what are all the basic emotions, isn't it? You may have an opportunity if you're really studious or have small, very less amount of motivation in your regular college hours, you must have heard about basic emotions called anxiety, anger, fear, happiness, disgust, isn't it? All those emotions we would have at least heard. But what about students from other streams? They may not be really able to understand or tell what emotion that they are actually feeling. Right? Any psychologist will definitely have emotional dysregulation. Any individuals can have. We're all humans. But as a psychologist, may have slightly greater level of awareness where we can easily label it. Right? But individuals who are not from psychology background will have a lot of limitations in just labeling their emotions itself. Right? So that's what the first kind of activity what dialectical behavioral therapy is talking about. Right? They are mentioning about identifying and labeling emotions at any part of time, with their using their mindfulness things or using their improved self-awareness, they can see or they can just be aware of what they are actually feeling at that particular point of time, rather than judging it, rather than trying to refuse this particular experiences, rather accepting it, whatever that we are feeling. Right? That's what the first kind of technique this emotional dysregulation stands for. And then second part is about this understanding the function of emotion. And then I generally ask my client that why would we feel anxious? We can just ask them, right? Or what makes you anxious, or what is the general tendency, or why do any individual should feel anxious? Every primary emotion, right, or every complementary emotion will obviously have a functional, isn't it? They will definitely have some or the other purpose for it to continue, right? So imagine the process of evolution. If any part of the body is not useful, if any part of the cognition is not useful, or emotional part is not useful, would we carried it on our ancestors? Would have carried from our ancestors? Definitely not, isn't it? It would have definitely extincted over the evolutionary process, isn't it? We are carrying all those emotions just because it has a functional approach. It definitely has some or the other functions. What is the primary function of fear? To escape from danger. What is the primary function of anxiety? To avoid fear. Sorry, to avoid threaten, or to avoid threatened stimulus, isn't it? So escape from the threatening stimulus requires fear. Or, and then if you in case anxiety will help you to avoid the fearful or threatening stimulus, right? Okay, so that's what, like every emotions will definitely have some or the other functions in it, right? So that is very important for us to mention. And then we can ask them, like most of the people would have the sadness as a primary response. And then I would definitely insist everyone to watch what is that movie, Inside Out. Right. So happiness realizes the importance of sadness. In the first part, it recognizes the importance of sadness just by scrolling out the timeline. Just whenever the child or the protagonist feels anxious, or whenever that she feels sad, it gets supports. It gets emotional support from their parents and also from friends, so that they started to feel happy, isn't it? So every emotion definitely have lot of functions. So it is essential for us to make individuals to understand and what emotions that they are going through, and then why or what would be the primary role of that particular thing to pop up, right? Okay, and then we also have ABC skills: accumulating positive events, building mastery, and then hope ahead. As in accumulating positive experiences, that they have to proactively engage in the environment so that they gain positive experiences, right? And then building mastery is about improving their skills or improving their competences in any one or two areas which is essential for their functional requirement or the challenges that they face. And then we also have another C called coping ahead. So cope ahead isn't that they have to predict what are all the challenges that they can see in the near future, and then working towards that, and then trying out a list of techniques or list of strategies to overcome that is what is called cope ahead. And then there is also another thing called 4D technique. Right. So 4D technique is it is a very handy technique to manage an individual's anger. For example, the 4D stands for delay behavior. Whenever an individual feels a high amount of anger, they just have to, rather than expressing it or acting on that particular emotion, they can delay their behavior. Right. And then second factor is to take a deep breath and then distract themselves and drink water. Delay behavior, deep breathe, distract themselves, and drink water. These are all the 4D techniques, right? So I'll try to wind up now, and then I would be very happy to take up the questions. So I'll just scroll down the other things called distress tolerance. Again, we have multiple techniques. I've just mentioned very few here. And then again, there are multiple techniques under interpersonal effectiveness. And then all these techniques, distress tolerance and then interpersonal effectiveness techniques can be widely used across not just on mental health conditions, across the psychological problems and any individual can go through. Right. Okay. With this, I'm done with my presentation. I would like to take up questions or inputs from the audience. Appreciate the transparency with which you are sharing your experiences. Help us learn. Thank you, Triti. So I'm so sorry, Mukherjee. That's it. That's easy for me to pronounce.
Excuse me.
Yes.
Could you please move back to the previous 2 slides so that while you're answering their questions, maybe I could jot down the points which you were just rushing.
Sure.
Thank you so much.
How many sessions required, sir? Okay, as I mentioned earlier, most of the time we cannot directly tell any client that this much amount of session is required for them to get cured. Rather, we can tell them that generally when it comes to counseling things that the general number of sessions ranges between 8 to 12. And then when it comes to psychotherapy, I mean, counseling is for individuals having psychological problems, and then psychotherapy is for individuals with mental illness. That's what the difference between these two things. And then there are again various differences. I'm not going into the details of it. Again, when it comes, whenever that we are going to tell them about the broader number of sessions, we can roughly tell them between 8 to 12 sessions, and then we can tell them after 4 or 5 sessions, you will find some changes within yourself, right? So that can be done. DBT can be done online. Any form of psychotherapy can be done online, provided that we are sticking up with this ethical the technical norms within the session.
Sir, a question. So how can
yes, I request every participants to kindly drop their questions in the chat section, because there are a lot of people who are waiting in the chat section.
so
Yes, I
I've
hope you will understand.
given my question twice, sir.
Yes. Awesome, extensive information. Thank you, Anita. New learning, how many sessions required? How could DBT be applied to facilitate therapy when working with children with neurodevelopmental disorders like autism? Right. We primarily need to understand the application of every techniques. For example, most of the time, children with autism would definitely require behavioral techniques. Right? They may have definitely have difficulty in applying this cognitive behavioral therapy techniques, but how can we expect them to integrate this acceptance and non-judgmental attitudes and all? Right? So it's not advisable to apply all these techniques across conditions. For predominantly for neurodevelopmental disorder, ABC things, and then ABA factors, and then this behavioral therapy techniques would be very appropriate. Durmi Singh. PPT will not be shared, Geeta Katwani. 4D is drink water, delay behavior, and then what is that? Deep breathe, and then distract yourself. This whole session would be has been recorded, and then it will be uploaded in our YouTube channel. We'll share the YouTube link to you. You can watch it then. We are expecting one more session in detail, sir. Sir, the thing is that we will be conducting a detailed session, as in it's not a session, it will be a course. We'll conduct around for 8 to 10 sessions, which is obviously required for you to equip yourself in DBT. DBT certification, will you start training? Yes. Yes, Geeta, we will be rolling out our program in the month of Jan. Okay, thank you. Can you share the PDF in the group? Okay, is DBT required 12 sessions individually? That's what, Sangeeta, like we cannot specifically mention the number of sessions. That's what the thing that I'm again mentioned. We just roughly mentioned that the number of sessions is between 8 to 12 sessions for a counseling setup. And for a therapy setup, it is between 16 to 20 sessions. And then if at all that the individual has a personality disorder, again, we may have to consider this for a very long term. Okay, so it's all feedbacks. Thank you. DBT in oncology setting, definitely yes. Individuals would be having high amount of distresses, which would definitely helpful them to have this distress tolerance techniques would be very helpful in oncology setting. Okay, can you elaborate on how to understand when a client needs clinical intervention, especially we're using DBT techniques in counseling? As I mentioned about the two factors, high amount of distress and then high amount of dysfunctions. These are all the two primary criteria which you can stick to, right? To understand the amount of the intervention from a clinical aspect. It's been a long time since a passionate explanation. Instead of focusing on PPT, I focused on lecture. Thank you, Deepthi. Very insightful session. I want to make notes of the function slides. Okay, I hope I shared it, Manya. Okay. Thank you. I'm interested in meditation. You think mindfulness is meditation, and there are some people who finds it hard and boring too. That's a condition. We can help them understand the importance of mindfulness. Amantika, as I mentioned earlier, most of the time I try to disclose about myself to insist the importance of mindfulness. I'll try to give my personal example with the boundary of this self-disclosure. Thank you. CBT and DBT in practical terms. I hope I have mentioned CBT considers acceptance as the last resort. Rather, DBT insists it as the primary factor. That's what the one thing that I can immediately come up with. There are a lot of other techniques also. That's what, like DBT, as I mentioned, like we rather than focusing it as a one form of strong therapy or a very structured approach, rather we can take up a lot of techniques, whatever that the DBT has been mentioning about this four components thing, where I wanted to spend more time on. You can obviously use all these four components called mindfulness, mindfulness, this interpersonal effectiveness, and then distress tolerance, and then what's that last factor, emotional regulation. These factors can be definitely be useful across the conditions. How can start training? Difference between ECT and DBT? Right, and then there are only two specific informations what our coordinator would want to share. I would ask our coordinator to take over the session. And then thank you so much all for your active participation, guys. Yes, it was very. I felt very privileged to address such a huge gathering.